Welcome back to part 12 of our 150-part IPDRG masterclass. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'm absolutely thrilled to have you back. Today, we're tackling a real game changer in inpatient coding, kidney disease. The rules here? Yeah, they're strict, but once you lock in the logic, they make perfect sense, and they have massive implications for your facility's severity capture and reimbursement. Okay, let's take a quick look at today's agenda. We'll start with an introduction and recap, then hit clinical indicators for renal failure, the 6 CKD stages, sequencing rules and combination codes, IPDRG severity impact and CDI, and finally wrap up with a summary and next steps. Right, let's dive straight into Section 1, Introduction and Recap. Just a quick look back at the foundation we built last time. So last session, we mastered combination coding for systolic and diastolic heart failure. We saw how vague terminology, like just saying CHF, basically forces us into a lower-paying DRG. We also walked through linking heart failure with hypertension. Well, I really want you to keep that exact same hierarchical logic fresh in your mind, because the rules we use for heart failure combo coding, they apply directly to the kidney disease rules we're diving into today. Moving right along to Section 2, Clinical Indicators for Renal Failure. Before we even think about assigning a code, we gotta know what we're looking for in the labs. We absolutely must differentiate the sudden, rapid onset of acute kidney injury from the slow, progressive decline of chronic kidney disease. AKI, which you'll find in category N17, happens incredibly fast, over a period of hours to days. You're going to spot this in the chart when you see a sudden, sharp elevation in the patient's current serum creatinine compared to their baseline, or maybe a massive spike in BUN. You might even see hyperkalemia or sudden oliguria. Now, on the flip side, CKD in category N18 is a gradual, long-term decline. It's an ongoing chronic condition the patient just lives with and manages over a long period. Now, what's really fascinating about acute tubular necrosis, or ATN, code N17.0, is that the term itself is actually a bit of a medical misnomer. ATN is the most common intrinsic renal cause of AKI, meaning the pathology is literally inside the kidney itself. But it's a misnomer because, clinically speaking, cell damage is minimal, and it isn't entirely limited to the tubules. Crazy, right? But regardless of the name, if a physician documents ATN, it's an essential diagnostic condition that we have to capture. So as an inpatient coder, you know you're constantly facing these complex scenarios where a patient comes in with multiple acute issues at once. You might be wondering, how do we sequence AKI when the patient is also admitted with severe dehydration? Like, which one gets that coveted principal diagnosis spot? Well, the reality is, there's no rigid rule saying AKI must always be principal. None. Sequencing depends entirely on the reason for admission after study. Basically, the focus of the treatment dictates the principal diagnosis. So, if the primary focus was aggressive IV fluid resuscitation, mainly to treat the dehydration, then dehydration might be your principal. But if the focus was managing the renal failure, then AKI takes the lead. And hey, if the principal reason is unclear in the documentation, you absolutely must query the physician. Okay, on to Section 3, the 6 CKD stages. This is an area where precision is, quite frankly, non-negotiable. ICD-10 recognizes 6 official stages based on eGFR values, and these values tell us exactly how well those kidneys are working. Stage 1 is an eGFR of 90 or above, mapping straight to N118.1. Stage 2 is 60 to 89, mapping to N18.2. Then Stage 3 is actually broken down into 3A and 3B, mapping to N18.31 and N18.32. Stage 4 drops down to an eGFR of 15 to 29, which gives us N18.4. Stage 5 is less than 15, that's N18.5. And finally, end-stage renal disease, which requires chronic dialysis, is N18.6. This whole breakdown demonstrates exactly why documenting this specific stage is so mandatory and why we have to avoid that unspecified N18.9 code like the plague. Seriously, unspecified codes just cause revenue leaks and huge compliance risks. Next up, Section 4, Sequencing Rules and Combination Codes. Let's get into the complex logic of sequencing when a patient has multiple superimposed conditions. Very often, you're going to see a chart where a patient experiences acute renal failure, superimposed right on top of pre-existing CKD. When this acute on chronic scenario happens, the guidelines are super clear. You must sequence the acute kidney injury, code N17.9 first. Then, you follow it up with the specific chronic stage from category N18. Remember, acute conditions generally take priority in sequencing because they are the immediate resource-heavy reason the patient is in the hospital. Now let's bring hypertension into the mix. Because ICD-10 presumes a direct cause and effect relationship between hypertension and chronic kidney disease, you have to use combination category I-12 whenever both are documented. You'll use I-12.0 if the patient is at stage 5 or has ESRD. You use I-12.9 if they're sitting anywhere from stages 1 through 4. But here is the absolutely crucial part. You can never, ever forget to add the N18 secondary code to identify the exact CKD stage. The I-12 code tells us they have hypertensive CKD, but that N18 code, that tells us exactly how severe it is. And taking it even one step further, if your patient happens to have hypertension, heart failure, and chronic kidney disease all simultaneously, you must elevate your coding to category I-13. This single, powerful combination category captures the intertwined nature of all three of these systemic diseases. And just like we discussed a minute ago, you'll still need your secondary codes to specify the exact type of heart failure and the exact stage of the CKD. That's the only way we accurately capture the true severity of the whole shebang. Moving on to Section 5, IPDRG Severity Impact and CDI Queries. Let's look at how all this coding logic directly builds your facility's revenue integrity. Understanding the weight of these codes in the grouper is literally vital. Acute kidney injury and acute tubular necrosis are major complications and comorbidities, or MCCs. Capturing an MCC significantly boosts the relative weight and the reimbursement of a chart, basically because it reflects a much higher intensity of hospital resources. Meanwhile, advanced CKD, specifically stages 4, 5, and ESRD, act as standard complications and comorbidities, or CCs. If you leave these out or rely on unspecified codes, you're just leaving rightful reimbursement on the table, for sure. Check out this real-world CDI query where one tiny detail made a massive difference. We have a case where a patient had a secondary diagnosis of N17.9 for acute kidney failure, but the documentation was missing the present on admission, or POA, flag. So the coder sent a compliant query to the physician, just asking to clarify if the AKI was present on admission or if it developed during the stay. The clinician confirmed. It was present on admission. Boom. That simple yes shifted the MSDRG from 293, heart failure without CC/MCC, all the way up to 291, heart failure with MCC. Just by securing that POA flag, the facility secured the higher payment for the complex care they actually delivered. Here's another prime CDI query opportunity you really need to watch out for. What if you're reviewing a chart and the physician only documents super vague terms, like renal insufficiency or azotemia, but then you look at the labs and you see a massive creatinine spike? Say it jumps from a baseline of 1.0 all the way up to 3.5, and you see the clinical team aggressively treating it with IV fluid resuscitation. Well, that is your cue. The clinical picture looks exactly like acute kidney injury, but you know you can't code AKI based on labs alone. You must send a compliant, non-leading query to the provider presenting these clinical indicators and asking them to confirm if the patient actually had acute kidney injury. All right, bringing us to Section 6, Summary and Next Steps. We have covered a huge amount of technical coding logic today. Let's lock in those core takeaways before we wrap up this explainer. First, remember to differentiate these conditions by their onset speed. Rapid means acute, gradual means chronic. Second, always pin down that exact CKD stage and avoid N18.9. Third, properly sequence acute and chronic conditions by putting the acute code first. And finally, be proactive. Aggressively query vague documentation like renal insufficiency when the clinical indicators scream AKI so you can capture the true clinical picture. Make sure to join me in Part 13 where we'll tackle another massive driver of inpatient severity, the intricate rules of diabetes mellitus. We're going to cover categories E08 through E13, how to correctly link complications, and the severe MSDRG impact of diabetes ketoacidosis. Trust me, you won't want to miss it. I want to leave you with a challenge this week. Review your charts and really ask yourself, is vague terminology holding back your coding accuracy and costing your facility? Go hunt down those missing CKD stages and clarify those vague acute kidney injury terms. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep coding with confidence, and I will see you in the next masterclass.